University of Melbourne, based at the Albert Road Clinic in Melbourne, Australia. He specialises in clinical aspects of mood and anxiety disorders, psychopharmacology and psychiatric aspects of acquired brain injury. In the past, he led the Psychological Trauma Recovery Service, incorporating the Veteran Psychiatry Unit and the Victorian Brain Disorders Program, Austin Health. He's held senior positions with the Royal Australian New Zealand College of Psychiatrists, including past chairmanships of the Victorian branch and the Board of Research, and was president of the college from 2015 to 2017. In 2017, Professor Hopwood was installed as President-elect of the Asian Federation of Psychiatric Associations. In 2017, Professor Hopwood commenced as interim head of the Department of Psychiatry at the University of Melbourne. So would you put your hands together and give Professor Hopwood a warm welcome.
Thanks for that. It's kind of interesting. I always find it slightly awkward listening to someone talking about themselves. So I kind of half concentrated thinking Australia, New Zealand, Asia. I'm not quite sure what happens after that. It sounds a bit it sounds a bit frightening, really, doesn't it? Anyway. So the topic for tonight is treatment-resistant depression. And I've got some slides making some points. But as always with this group, I very much like to make it of the most use to you it can be. So if at any point you think, I want to ask about that, or he didn't mention that, but I really want to ask about that, please feel free. I actually don't care if I don't get through the slides at all. It's got to be the most use to you. So we'll talk about it a little bit. I think I'll still put that disclosure thing up because I think it's still important that no matter which audience you're talking to, who else do I work with and who do I get research from, and I think it's important to be open and honest about that. Some people, when they show slides like this, kind of say, well, I can't be biased because everyone supports me. I don't know that it actually works for me. That kind of sounds a bit of a cop-out, but I'm involved with a lot of different people and I'm happy to acknowledge that. I guess just in talking about treatment-resistant depression, it's a topic I'm really pleased to talk about. This is from the World Health Organization Global Burden of Disease Study, and I kind of like talking about this because it makes good recognition that psychiatry is important, but it's kind of not a good news story really, is it? That depression is now the second leading cause of disability in the world. It's not really great news. It's kind of interesting, it's moved up amongst the leading causes of disability, mainly because some of the conditions you see on the left in 2000, and I'm not sure if we can turn the lights down a little, it might be a little bit hard to see the slides. I was just looking back thinking, oh, I can't read it. There was some diseases, there were actually slides there you go. A few conditions that were prevalent in particularly the developing world and would cause infant mortality are now gradually improving, and diseases that occur in teenage and adult years first, like depression, are becoming a greater cause of disability. So it's kind of good and bad news in a way, isn't it? But it definitely means that depression should be an incredibly important part of what we're aiming to do to improve the health of the community. And I suspect most people here would accept, please.
Hi, Malcolm, I'm Ingrid Ozols.
Hi,
Ingrid. And I'm hoping to ask you, when we look at that scale, and we've been talking about those statistics for decades now, and now that it's here, which is scary because I've been in this patch for a while now, when we talk about depression, are we talking about umbrella of depressive and affective disorders, or are we talking about certain type of depression, or is it all of them?
It's a great question. We're generally talking about depression as defined in DSM. Now, it's not the Bible, despite what the newspapers say, it's just a cookbook that describes ways of describing mental health diagnoses. And so that'd be people who have an illness lasting at least 2 weeks, causing significant impairment in their life. It's not bipolar disorder, it's not grief, and it's not a sort of adjustment to a situation in life. It might start out occasionally as adjustment to a situation in life, but it's more than that now. And it'd be the classic symptoms of low mood, loss of enjoyment, and then the sleep, the appetite, and of course it varies in severity. So, depression, the name major depression implies that all of it's bad. Well, I suppose all of it is bad, but there's still mild, moderate and severe within that. And it's like a lot of things, that frequency is a pyramid. So mild is commoner, moderate, less common, and the most severe, the least common, but it's still pretty common in our community. So if 20% of people have an episode of major depression in their life, that means probably about 2 to 3% will have an episode of severe major depression. And, relevant to tonight, for about 20% of people who have depression, depends a little bit on your definition, about 20% of people, it'll become treatment resistant. Now we'll talk a little bit in a minute about how you define that, because that could be really complicated. But 20% of 20% of the population is still a lot of people. And by definition, if you've got treatment-resistant depression, you've probably had it for a while, right? Otherwise, how do you know it's treatment-resistant? You've got to have it for a while to know that. So we're talking about quite a lot of people suffering an ongoing burden and affecting their families and everything else. That's an important problem. In trying to define it, I just want to make a few points, and hopefully that answers the question. Well, my best attempt, there you go. Sometimes when we talk about treatment-resistant depression, it's easy to get confused with a few other terms that we toss around a bit. One of the first things that's easy to get confused about is treatment-resistant versus recurrent. Recurrent simply means it's come back again. It doesn't automatically mean it's treatment-resistant, it just means it's come back again. But actually that's important, because it's got a habit of coming back again. So this study shows, it's an old study, but I think it's still a good message. Well, an important message, probably a better term really. If 20% of the population had an episode of major depression at some point in their lives, if you've had one, your risk of having another one again during your life goes up, which sort of makes sense, doesn't it? You wouldn't be surprised by it. It actually goes up in this study to about 50% risk, thank you very much, of having another one in the next 5 years. By the time you've had 3, and this is not necessarily with treatment, by the time you've had 3, your risk of having another one in the next 5 years is probably about 80 to 90%. Now in a way, I kind of feel bad talking about those figures because they are scary. But the importance of talking about them is to be real about them. Because people getting treatment for depression and us treating depression is no different to most things in life. You feel better, and what do? You think, I don't really want to take these medications anymore, they don't make me feel good about myself, or I don't want to go and see the therapist anymore, or that problem in my life that I've sort of is a bit difficult to deal with, well, I'm feeling a bit better now, so I'll just shelve that. And I'm sure no one in the room would do anything like that, but it does happen, I've heard. It does happen. So the message that it's recurrent is an important one. It's not, recurrent depression isn't necessarily treatment resistant, because each time it happens you might be able to treat it. It would be good to stop it recurring in the first place, would be another way of looking at it. There's also another different idea. You can't be treatment resistant if you haven't had treatment, I guess. It wouldn't quite make sense, would it? And actually, an awful lot of depression in our community is untreated. So the best estimates say only about 50% of the depression in the Australian community gets treatment. And they're people who meet those criteria for depression, like we were talking about before. Clearly, the more severe it is, the more likely someone will get treatment, because, it causes more marked disability. It makes sense, doesn't it? So it's milder depression that often goes untreated, and sometimes that will get better by and of itself. But we talk a lot in other types of mental health problems like schizophrenia or psychosis, that the longer you go without treatment, it's bad for you and bad for your long-term future. kind of like if you leave it untreated for too long, it resets things in the brain, if you like, and probably resets things in your life, if you think about it. Actually, the same might be true for depression. And actually, if you stop and think about it, well, it's not so surprising that the duration of untreated depression, call it a delay in treatment if you like, but a duration of untreated depression, this study looked at if it was more than 12 months or less than 12 months someone had depression. And the longer they went untreated, it predicted things like not just this episode, but how likely they were to have a recurrence in the future, how likely they were to have hospitalisation, and sadly how likely they were to harm themselves in some way. So that's actually quite important, and maybe we don't talk about that message quite enough. We talk about the urgency of getting treatment for a whole lot of medical things. Now, don't we? If you look at the public health promotion about stroke, it's all about urgent, urgent, urgent. Well, this is not urgent as in the next 30 minutes kind of urgent, but it's urgent enough. And I think we need to talk about that. It's not the same as treatment resistant, but it's an important group too. There's another important issue, and that's about how long it's gone on for and how likely you are to respond for treatment in this episode. So this study looks at people who got treatment. How many of them got better over a given time period? So the first column over here on your left, in the first 6 months, just over 50% of people recovered. In the next 6 months, by the end of 1 year, up to about 70% had recovered. By the end of 5 years, it was actually over 80%, but it's good. 5 years is a long time, but over 80%, well, it's pretty encouraging. If you look at the grey bits then, these tell us how many more people got well during that time. So, if you'd already been depressed for 4 years, only 1 out of the remaining 16% got better in the next 12 months. So you've been depressed. I'll explain it again because those numbers are a bit confusing, aren't they? Maybe I didn't explain it very well. Been depressed for 4 years, continue with treatment. Of the 100 people who started the study, there's only 16 of you left still unwell. Over the next 12 months, only 1 of those 16 is going to get well. That doesn't sound too good. The 80% sounded much better. I'll take that one every time. What does that mean? Well, it could mean a whole lot of things. If you've been depressed for 4 years, is that going to affect a whole lot of aspects of your life? Well, it certainly could, couldn't it? Could affect your work, could affect your relationships. Could it affect your way of viewing yourself and the world, your psychology, if you like? Well, it certainly could. I don't think that's too hard to understand. Could it also affect you biologically after being depressed for that period of time? Yes, I think it may do that too. It could do all of those things. So timeliness is important. This is talking about treatment-resistant depression now. These were people who were getting treatment. So one of the great mistakes we can make in treatment-resistant depression is waiting too long to move on. We'll talk a little bit more about that balance in a minute. But one of the issues is how long on any treatment do I need to wait before I know it's going to work? It's one of the commonest questions I get asked, and I think it's a really important practical question. Of course, it depends a little bit on what the treatment is. But for an antidepressant, we have pretty good evidence now. People often talk about 6 to 12 weeks. Well, that's a heck of a long time if you're not feeling very well. It's a heck of a long time, full stop, you could argue. In fact, that's the time frame it takes for a person to have the full response they're going to have. And we've got pretty good evidence now that if you're on an antidepressant at a given dose, doesn't matter which one, if nothing has happened in the first 2 weeks on that dose, the chances it's going to happen at all are getting pretty low. And at some point we've got to balance those chances with the risk of staying depressed for too long. That's not good for you either. So generally now I'd be saying if nothing's happened at 2 weeks, I'd be looking to either change the dose or move on. And we'll talk about all the options in a minute. but it's a really important principle, and I do get asked that question a lot. You know, a similar question is, how long do I stay in a particular form of therapy? That's quite a tricky question, that one, because there's so many factors that go into that. It's very interesting. If you look at the Better Access scheme, where people can access seeing expert clinical psychologists through Medicare, and usually get 6 or 12 sessions funded, and how many sessions, the right number of sessions, we'll debate another day, but you know, they get some sessions funded. The average number of times people go, anyone want to guess?
Once.
That's the commonest. You're absolutely right. And the average number is 3. So some people go 12, but the average is 3, which is very interesting. Now, maybe a whole lot of people go for one session, get a blinding insight, and it's all fixed. I'm sure sometimes that's true. They're not the people who see me, because I never seem to fix anyone's symptoms.
Sorry, do you think that would be for the worried well?
Well, that's possible. You know, if we look at the number of people being referred to Better Access, it's expanded dramatically compared to what the government initially expected. But I don't think most of them are. I really don't think
the
that.
ones that go for the short period.
But that's the commonest number. So there's no way of telling for sure. No, I think more important, you know, because it's hard to know sure. I think more important is that just like people don't always stick to treatment with medications, they don't always stick to treatment with therapy either. It's actually no different. Somehow we might think about that differently because it seems a different form of treatment. So it's a problem with whatever sort of treatment that we need to stick at it and do it in a timely fashion too. That'd be my take on it. Can I prove that from those numbers? You could argue not. You could argue not. It's not a criticism of any discipline or people involved. It's more a comment, I think, on how we approach and think about treatment and maybe talk about treatment, I think, more than anything else.
Yeah. So tell me again, what does that figure, does that 1 or 3, is that on everybody who attends?
Everybody who goes to Better Access. Now that will include people with a whole range of problems.
What do you mean Better Access?
Sorry, let me explain. So Better Access is a scheme under Medicare where your GP can refer you to generally an allied health professional for a finite number of sessions for particular kinds of therapy. It's true that people with all sorts of problems can be referred there, but we know that depression and anxiety will be the commonest. There's little doubt about that. The numbers say the commonest number of times people go is once. Now that could be because their problem's not that big, and maybe just having one talk, things get better. Although my hunch is that's a minority.
They're uncomfortable with the process.
Well, I think, it's now I'd be guessing.
Don't engage with the therapist.
Either way, you know, just like we have guidelines about medication, the guidelines about cognitive behavioural therapy, for example, none of them recommend 1 or 3 sessions is enough. So people are stopping earlier than we think they should. Now, either the guidelines are wrong or something's wrong, but we're not quite getting the message connecting somewhere in there, I think. Ingrid, please.
As a consumer care advocate, there is evidence that actually suggests the reason why people are not going more than once to a particular professional is because of stigma. They feel stigmatised by the professional. They don't feel comfortable by the professional, so they're staying away. And they are sick of the 20 questions. They don't want to keep trying to see other professionals. So there's a whole range of reasons why there's only one visit, and predominantly is still, and has been so for many years, that stigma is still one of the biggest evils in our social community that keeps people from getting help, not talking about it, not recognising when they're in trouble, and not feeling comfortable asking for it. Shame.
Look, I'm sure there could be rights, and I accept that completely. It's certainly still a problem, isn't it? And resolving that to make treatment, and that can apply to medication as well, of course, too. That resolving that to make it feel like a comfortable, logical exercise would be a real advance, no doubt about it. All right, if we're going to define treatment resistance, it's worth just talking for a little minute about, well, what are the treatments people first usually use, because usually treatment resistance is going to be defined something like the first couple of usual things haven't worked, if that kind of makes sense. Well, and it's important to acknowledge it's not a rare event. So this is a study that looked at how well do our first line antidepressants work. When I went to medical school, I was taught that if you take an antidepressant for 6 weeks, there's about a 60 to 70% chance that you will have a good benefit. Not full recovery, but a good benefit. And if you compared that to placebo, that'd only work in maybe about 20 to 30% of people. So that's a pretty big difference. You think, sounds like I'll buy that car, I think. That sounds like a reasonable deal. Well, this is a more recent study looking at the last 10 years. The response rate seems to have gone down. And the placebo rate's gone up to 37%. So suddenly the gap's only about 15%. What does that mean? And we know that there's a big public discussion about antidepressants. You don't have to go very far on the web to kind of run into that, do you? What does this mean? Are we making better sugar pills? Maybe, although the world tells me sugar's bad now, so I don't think it's just that. I think probably the way we do trials is a little bit different now, that generally people in trials, their depression's not quite as severe, so there's a better chance they'll get better just with probably the support that happens in a trial. Because in a lot of trials for medicines, you get to see a psychiatrist and a research assistant who's probably nicer than the psychiatrist. You get to see them weekly for about 4 weeks and then fortnightly for 4 weeks. Most people don't get that level of support in their treatment in routine care, is probably the truth. So that probably contributes a fair bit. It is a worry that we're not producing new antidepressants with a better response rate, and that's true. Most of us think that figure's a bit low, but if you look at people who have a full recovery, which is really what we should be aiming for with an antidepressant over 8 weeks of treatment, with any given antidepressant, it's only about 40 to 50%. It's certainly not as good as we'd like. There's no point pretending. Does that mean that we may have to try more than one to find the right one, or to attempt to find the right one? Yes, absolutely. And I think sometimes it's important we're open about that at the start, because if you expect the first one's going to work and it doesn't, if it was oversold to you, that's going to be a pretty disappointing experience. And it is for many people. If you're already feeling depressed, guess what? The treatment didn't work. Gee, that's making me feel better. No, that's not. So I think it's important to be quite clear about that. Funnily enough, actually in preventing depression, so this is looking at preventing depression once you've had it, the evidence that the medications work is slightly better. It says if you have an episode of depression and are treated successfully with an antidepressant, if you go on to placebo, your chance of having another episode in the next 12 months is up around 40%. So you might remember I talked about some numbers about relapse rates earlier. That tells you the highest risk is in the first year or so after you've had an episode. Which sort of makes sense, doesn't it? You're not surprised by that. If you're staying on medication in this study, in the dose that got you better, the risk goes down to about 15%. Actually, that's not bad. That's not bad. I can tell you, and I haven't got the study here in front of me, but a big study we did looking at about 40,000 Australians taking antidepressants, is that the average time people pick up a script for their antidepressant is for 3 months only. 50% of people don't pick up a script after 3 months. Now, just because you pick up a script doesn't mean you're necessarily taking it. What does that mean? It could mean a lot of things. A bit like that 3 sessions. What does it mean? It's speculation, isn't it? But no guidelines talk about taking medication for that long. It's just as no guidelines talk about psychotherapy for that long. And all the factors we discussed earlier might play a role. So if we sometimes need to try more than one treatment, what happens to your odds of responding by the time we get to treatment resistance? Actually, treatment 1 in this study, STAR-D, was the biggest ever sequenced treatment of depression study, and it included medication and psychotherapies, which isn't always the case. They're often kind of kept a bit separate. So in that sense, it was a bit more like the real world. Did it necessarily pay attention to all the other issues that might be relevant in a person's life? Probably variably is the answer. It said, almost no matter what treatment you had, just under 40% of people got completely well, in remission, with the first treatment. That's about what I said before. The second treatment, no matter what it was, just slightly less, about 30% got better of the ones who needed a second treatment. If you kept going, not surprisingly, by the time you needed a third or fourth step, the rate of responding to it is lower. Kind of says, well, if you get into that, there's probably going to be some factors that are making it more challenging. Sometimes we know what they are, sometimes we don't. By the end of 4 treatments, 2/3 of people had got into remission overall. It's not too bad, except if you're in the other third. But again, should we talk about these numbers a bit more before we start treatment? I actually think we should, because it's the kind of conversation you have in other areas of medicine, isn't it, about what things look like over the next 12 months. Because by the time you work your way through 4 treatments, even if you're going through a bit quicker, it's still going to take a while. We're still talking about quite a few months. I actually think sometimes we should talk about that a little bit. It's a fine balance between talking about things that are going to make you feel more despondent and things that are going to make you feel like you're on a logical path at least.
Because people, would they be getting discouraged and they would
Well, that's the risk. Yeah, it's tricky.
experiencing side effects as well. And then
Some of it will be bad side effects. Yeah, I think it's a tricky path for health professionals involved in treating depression. That some of this news is it's real, but it's a bit tough, isn't it? So how do I talk to someone the first time I meet them? And usually, of course, by the time they meet me, they've already tried probably at least 2 steps, and quite a few more is the truth.
But what steps do you mean, different medications?
Yeah, or psychotherapies. This study had both. So different treatments. Sorry if I wasn't clear. How do I talk about that logically? I just think we need to be careful that if only 40% of people are going to have a full recovery with that first treatment, that means 60% of people is setting up for disappointment if you don't warn them about that. I try to think, well, what would I like to know? Now probably I'm entering that conversation from a different spot, aren't I? Because I know stuff already, so it's a bit hard to imagine. But I think I'd like to know. I think. But people are going to vary in that, aren't they? And one of the skills is judging how much information does this person want at this time and asking them how much they want. It's a tricky judgment sometimes. Please.
Would you say by step 4 that major depression is still the best conceptualisation of what's going on?
Well, clearly at some point, well, really at every point, if a treatment hasn't worked, the next question to ask myself is, well, have I missed something? Is this the right diagnosis, or is this the only problem that's going on? Have I missed the fact that something incredible has happened in this person's past, or in their current workplace, or their relationship, or their physical health? Or in fact, if I ask again, they really were drinking an awful lot of alcohol that I missed the first time.
In this study, they kept meeting criteria for major depression along the way.
In this study they did. It's a really important question. Good, but in the sort of real world outside studies, certainly for me, checking again and again, hang on, are we missing something here? Is part of the reason we're failing, we're missing a big part of the picture? It's not always, the answer is not always yes, but it's an important question to keep asking. When do we call it treatment resistant? Well, it depends which textbook you read. There's no perfect agreement. Generally, it's been talked about more in terms of medication treatment, which is actually a problem, because in treating depression properly, the approach needs to be broader than that. So the College of Psychiatrists guidelines about treating depression that came out at the end of 2016 talk about biological treatments, psychological, social and lifestyle. And really good treatment pays attention to all those domains as is relevant to that person. But treatment resistant is talked about a bit more in terms of biological treatments. It's interesting why. We don't talk about treatment resistance in psychotherapy as much. There's not so many definitions, which is interesting. Some of the older versions of psychotherapy used to say there was no such thing as treatment resistance, just a resistant patient, which I always thought, I didn't particularly like that view, I must say. I thought that was a bit tough. Generally, in terms of antidepressants, the common definition is if you've failed 2 antidepressants that you've been able to have a proper go at. So we're not talking about one you had to stop early because of side effects, because you wouldn't know whether you were going to respond to that or not. But 2 you've been able to have a proper go at and you've failed, we'd say that's treatment resistant. In a way, the definition's not so critical. It's, well, what do I do? That's what counts, really, isn't it? So I don't generally say to a person, congratulations, you've reached the threshold for treatment resistance. I'm not sure that'd be an uplifting message, would it? You know, thanks very much, Prof. That's made me feel so much better. I feel a special person. So I don't talk about that with people. But it's useful because then we can develop studies that look at, all right, if we've tried 2 antidepressants and they haven't worked, and hopefully we've attended to those other domains properly as well, what should we do next? So we shouldn't assume that what worked at the start will work just as well now. What do we do next? One of the interesting parts of defining treatment resistance is it depends what you think success looks like. So most of our studies are based on rating scales for depression, right? Like some of you might have heard of, there's a Hamilton rating scale, Montgomery-Asperger rating scale. They're the ones that the doctor or psychologist does. There's the Beck that people fill in themselves. There's lots of others. But they all ask kind of about the same symptoms of depression. There's a really interesting, this is an American study, but there's been well replicated in Europe now, doing, an incredibly surprising thing. Asking patients, what do you think is the most important thing in feeling like you're back, you're recovered? Surprise, surprise, they don't necessarily agree with their doctor. They overlap in what they think. It's not a complete disagreement. So, patients in this study, there was actually 2 studies, but the results were similar. Up the top, they put the presence of positive mental health. So we ask about, do you feel bad? Do you feel guilty? Do you feel all the negative stuff? Patients in this study said, the most important thing in feeling better is that I feel positive things again. They weighted that more than the negative thinking. So I'm a bit worried that I don't want to feel low anymore, but I want to be able to feel joy. I want to be able to feel pleasure. I want to be able to look forward to things. It's kind of interesting that it might sound like, you might think, well, don't those 2 things go together? If you lose all the negative stuff, you'll get the positive stuff back. Not necessarily. They don't actually always go together in the way they behave. Second thing they rated as most important was feeling like their usual self. It's kind of a useful phrase, I think, isn't it? And it's about getting back into your old roles, I think, and just feeling like I'm back to the person I was is another way I think people express that. Feeling in emotional control, getting back to roles with family and friends. The symptoms of depression, in this study, they weren't asked it in this study. In this study they were, and they said, yes, that's important too. It's in my top 5, but it's not number 1. Whereas docs will often ask about all those classical symptoms of depression first. They should be in the mix, but is it conceivable that I could be thinking a person's treatment resistant and they're saying, actually, I think I'm okay? Well, it is conceivable. It tends not to be like that most of the time, but sometimes it is. And so there's room for a discussion there about, well, where do you think you're at? Where do I think you're at? Let's kind of see what the differences are in how we're thinking about that, because I want to be really careful that if we're embarking on an increasing number of treatments, that you and I both see that as a valuable thing to do, or not. Because if we're not agreeing about that, the chances it's going to have a good outcome aren't very good, are they? You know, you're not going to value what we're doing. What do we normally do if the first couple of things don't work? One thing people often do is increasing the dose of medicine. This is not just like when you start a medicine, and for most medicines there's a recommended dose range, so you stay within the recommended dose range. This is giving higher than that, and that's a pretty common practice. Is there evidence about that? Well, actually the reason most of them have a recommended dose range is because that's where the evidence is. It's done fairly widely, and I think it makes some sense that if you've had a bit of a response to a medicine but not a full response, and maybe you've already tried one or two others, increasing beyond the usual dose might make sense. But clearly, as you increase the dose of anything, the risk of side effects gets higher, so it needs close monitoring. Should we just wait longer? So this is what happens a lot if people have tried one or two treatments, particularly in general practice, and I don't want to sound too critical of GPs because I think they've got one of the tougher jobs going around, I really do. Solve any health problem you possibly can in 8 to 10 minutes. Go. It's pretty tough. But 90% of antidepressants in Australia are prescribed by GPs, and most psychotherapy is recommended by GPs in mental health care plans. So they're really important in this space. They often will stick for longer with the medicine, kind of a sort of a hopeful thing, well, if we stick at it for a bit longer, it might turn around. I sort of suggested before, actually, I'm not convinced that often the evidence supports doing that. And the longer you're left depressed, particularly once you've failed the first couple of things, it's probably not good. So I tend not to recommend that, but I actually see it happen quite a lot. So I would be tending to discuss, actually I think we should be onto it more, and more likely think about switching to a new class of antidepressant as one of those first two treatments. There was a bit of a phase for a while, whereas the first couple of antidepressants had failed, people thought, well, in diabetes we often combine medications, why don't we combine antidepressants? If one works 40% of the time, add in another one, maybe they'll go up to 80%. Kind of might make some sort of sense, I suppose. But actually it turns out it's probably not true. So this would be something that generally I would only reserve for not the first 4 steps, but a bit later. Psychiatrists vary in what they think about that, and that partly tells you the studies we don't have as many as we could. But I certainly will be doing the first couple. Yes?
A few years ago, I had a very bad episode of depression, and the psychiatrist put me on Zoloft.
Yeah.
And I still wasn't getting better. I was on 150. And then his prescription got to 200. I felt better. And I did feel better for a few days, and then I went quite psychotic.
Oh gosh. It sounds a funny thing to say given that unfortunate outcome, but is that a reasonable thing to do with that medicine? Yes, it probably was, because I have easily done the same thing. Yes, I probably would have, because that's in the recommended dose range. It does show, maybe, I mean I don't want to overdraw from your case in any way, but it does show treatment of depression is a complex business and there's no rule that fits everyone. And the treatments we give and the impact of the illness are powerful things. So we need to monitor them very closely. I'm sorry to hear that. That was clearly an unfortunate thing and tough. I sympathise with psychiatrists because I probably would have done the same thing, but I sympathise with you even more, for goodness sake. The commonest thing we do now, medication-wise, and yes, before anybody say, yes, I am focusing on the medication type side of things because I think that's probably where you wanted me to go, but I don't want to diminish the other side of things at all. The commonest place we go now is what's called augmenting. So this is adding a different type of drug to an antidepressant to lift, to boost the effect of the antidepressant. And there's two main, well three actually, main groups of drugs we use. So lithium, many of you recognise, was originally designed as a mood stabiliser in bipolar disorder. Discovered by an Australian, something we should all be proud of. A very unfortunate man not to get the Nobel Prize, I think. Lithium also has good evidence that in some people with depression that's resistant and not getting better, it can boost the effect of antidepressants and get you over the line. If it does that, it doesn't mean, oh, you must have really had bipolar disorder and we just didn't know it yet. It can actually work in depression as well. There was a big vogue back in about the 1980s, or so I was told by the people around at the time. There's a big vogue in the 1980s. Sorry, I'm wandering around and spoiling the camera. I'll wave a bit further. In the 1980s, there was a series of studies saying we'd known for a long time if you have a low underactive thyroid that can present with depression. So it's actually one of the tests we'd always do, just checking that's not present when people are depressed. So some people said, well, even if your thyroid tests are normal, maybe if we give you a bit of extra thyroid hormone, that will boost the antidepressant. And there were these studies that were positive. The only trouble was, when most of us got to use it, we had to say the results were pretty disappointing. I don't quite know why that is, but you know, when I get the opportunity to meet with other mood disorder, I don't use the word experts, but you know, other people around the world, pretty much all of them report the same view. So we do it occasionally, but it's quite down the list. More common now is using things that were invented as antipsychotics. It's interesting, once it has a name, antipsychotic, that sounds a heavy-duty name, doesn't it? But some of the newer antipsychotics, not all of them, have been shown to be useful in boosting antidepressants. Some of them we use short-term to help with things like severe agitation or even psychosis with depression. But separate to those, they can boost the action of antidepressants. So that's another thing we do sometimes when we've got treatment resistance. Now, these are not simple medications to use. They come with their own side effect burden. A number, for example, come with significant weight gain as a problem or over-sedation. So, you know, that needs to be weighed up pretty carefully and reviewed in their use. So, generally, this wouldn't be a strategy we'd be looking at if the depression wasn't moderate to severe. We're not going to be doing it if the risk benefit just isn't worth it, if it's mild. Using things from this group would probably be amongst the commonest strategies if a couple of antidepressants have failed.
They'll put the sticks and the crosses, man. Yeah, right, sorry.
Oh, sorry, they're distracting, aren't they? I should have adjusted this slide. It actually relates to whether they've got registration for this in Australia. Most of them don't, so I should be really clear about that. These aren't necessarily indicated for this in Australia, but they've got study evidence to support it. Good, sorry, it is distracting, isn't it? I apologise.
And when you say boost the effects of the antidepressant?
Correct, as opposed to being given by themselves.
What sort of boost do you mean?
Well, I think if we're honest, do we fully understand how they interact with the antidepressant? The truth is no. It seems that so if you've had, let's say, a 20% response to an antidepressant, adding these in lifts that in some people.
Subjective mood, is that?
Yep. Not just for anxiety and sleep, because that, you know, there are different ways of doing that, but actually for the core symptoms of depression, mood and so on. That's a very important question. It's a very important question.
So tell me, are you saying that the crosses mean they're not approved in Australia for use as depression?
Yes,
They're not approved, but people will still use them in Australia?
they do. They do. One of our problems in registration of medications that's a very important process, and quite rightly it's based for the TGA on is there sufficient studies. One of our problems in the area of treatment-resistant depression is it's not a very popular area to study, which is a great shame. If you're a company that produces a new antidepressant, guess what? You don't want to study it in people who are treatment-resistant because the chance of a good result is less. You'd rather test it in people who haven't had so many treatments because you've got the best chance of getting a good result. Is that helpful for the people who haven't got better with the first few treatments? No, not at all. So at times the amount of studies we've got in this group isn't anywhere near what we need. And the government will quite rightly say, well, you might think they're useful and you might have this evidence, but we demand a pretty high level of evidence, particularly before we're going to pay for it. And fair enough, I see where they're coming from. And as a doctor in that situation, it's a little like, it's not quite as rare, but you know, the sort of rare cancer and rare disease movement, they're rarer than this, but they have that same problem where they've got these really serious conditions, but they're never going to get enough studies to get drugs specially registered, or other treatments for that matter. But what do, you know, and if there's evidence for something, people are clearly going to want it. It's a tricky balance, because you don't want to take that as a license to just chuck anything at someone. That's bad practice, isn't it? That's just bad. So it is a tricky balance. It is a tricky balance. We mentioned before about if we're getting to the third or fourth step, whatever the treatment is, we better be thinking about have we got the diagnosis right. Some of them are obvious, so it's not just literally the diagnosis, also other factors like what's going on in the person's life. Is there some other, physical illness? Is there something at work? This slide just highlights some of the common overlaps, and bipolar disorder is obviously another really important one to think about. It can be such a hard diagnosis to get right sometimes. One of the best predictors that depression is actually bipolar depression is that a person has failed multiple antidepressants. Now you can fail multiple antidepressants for multiple reasons, but one of them is because it's actually bipolar disorder. They don't work as well on average for bipolar depression. So it's just one of those things we certainly have to keep in mind. If a person's only ever had the mild hypomania in the past, going back over time to say, has there ever been a time in your life when you've been excitable or full of energy, not slept as well for a few days? For those of you who happen to barrack for Richmond, the answer is yes. It's about September last year. So, mild mania can blur a fair bit with who a person is normally. It can be really hard to pick, particularly looking backwards. That's one I always keep in my mind as important. But equally, other things in a person's life or their past life can be just as important and need to be attended to. Please.
Just that slide, is something like persistent depressive disorder not the same as treatment?
Well, so the persistent depressive disorder is a DSM term. What they mean by that, they used to divide depression that went on for a long time into two types. If you still met all the criteria for major depression and it went on for more than 2 years, they call it chronic major depression. And then they talked about another group called dysthymic disorder that was meant to be long-term low grade. But actually, sometimes people who've got major depression get a bit better for a bit, but not fully well, and then get worse again. It's more mixed up than that. So they said, look, hang on, we think it's better to have a single category of persistent depressive disorder. And I think that's probably right. I think we've got to be a little bit careful sometimes of over-splitting more than reality means. It is important, of course, to have a sort of floor at the bottom of that of saying persistent unhappiness in life isn't the same as persistent depression. That's called barracking for Carlton. No, sorry, I'll take that back. You can tell who Richmond used to play grand finals when I was a kid, can't you? Please.
I was told that if depression was wrongly diagnosed as unipolar but was really bipolar, that antidepressant treatment could stimulate, trigger cycling between the states. There was evidence of that. I don't know if it still holds up.
Yes, it's a really important question. We used to worry about that a lot. The older antidepressants, particularly the tricyclic antidepressants and the monoamine oxidase inhibitors, could cause that relatively often. So they'd treat your depression and you'd shoot straight past up into a high or be dysregulated and sort of chasing, that's not helpful, is it? With the newer antidepressants, so the SSRIs, fluoxetine, sertraline, all those, and the others, the rate seems lower. In fact, we don't get many good studies in people we know have bipolar disorder. We often rely on the big depression studies where there'll be people who've got bipolar disorder who just don't know it yet and look at the rate of who's gone high during the treatment. And for most of the newer ones, particularly the SSRIs, the rate's about the same as placebo. So it's pretty low. And actually the bigger risk is if it is bipolar depression, they don't work as often. Which is interesting because they're called antidepressants, right? And this person's got depression as part of bipolar disorder. But they don't seem to work as often. Do we really know why that is? I don't think we do. So both can be risks. It's a whole lot. I realise this slide produced a whole lot more questions than I was expecting. I guess that's a good sign. Another possibility I think of is, well, there's both what the patient has a perspective on what they want and what I want, but there's also the symptoms we don't ask about so much. Cognitive problems, we think about them a lot in other types of mental health problems, don't we? Problems with attention, with planning, thinking clearly. They're actually very common in depression, and in 40% of people, they don't necessarily get better when everything else improves. So maybe this is an area in thinking about really getting better, we need to think about, a bit more. Similarly, Similarly, we need to ask more about positive emotions. This study was really to remind me about, talk about positive emotions, so I won't dwell on it. This, just for interest's sake, this scale over here, the SHAPS, is the Snaith-Hamilton Pleasure Scale. Apart from sounding like it's Harry Potter, imagine having your name attached to a pleasure scale. I think that's kind of cool in a way. Better than a depression scale in a way, surely.
Is that Valdoxin? Sorry to interrupt. Is it?
It is. Agamazepine Valdoxin. What this study showed, and I don't want to get hung up about one drug versus another particularly, both of these drugs work the same for the typical depression symptoms. Low mood, guilt, hopelessness, etc. They didn't work the same. The SHAPS measures positive emotions. They didn't work the same for that. What does that mean? I think we want to be a bit careful about over-concluding. What it probably means is we should be measuring that regularly in our studies too, because they don't always behave the same. Even though you might imagine, well, surely if you get rid of the bad stuff, the good stuff will come, right? It doesn't automatically flow. So it's a bit about, if we think about treatment resistance, we need to make sure we check all the symptoms properly. Now, what other things come up with treatment resistance? This is a slide to remind me to talk about ECT. The detail of this slide doesn't matter. All it is a study. All of the treatments that work for depression, psychological or biological, increase levels of a thing in the brain called BDNF. It's a brain hormone, brain-derived neurotrophic factor, that facilitates sprouting between neurons in the brain. Kind of sounds like a good thing, doesn't it, when you say that out loud? ECT does it too. That doesn't matter too much for what I need to say. ECT remains a very important treatment in treatment-resistant severe depression. It clearly has the highest response rate in that setting. Why don't we use it as treatment number 1 or 2 for people who are particularly likely to respond? And we can actually predict who they are. the answer is obvious because people are worried about it and very cautious about it. We have good information now about side effect profile, and it has one. It's not saying it's side effect free. We've developed ECT in awful lot. It's really very interesting with ECT. If you ever see a television program about ECT, the images you will see are from the 1950s. If you ever see, and that's probably true about images around psychiatric wards as well, actually. If you ever see an image about heart surgery, no one would ever show you heart surgery from the 1950s. I don't know if anyone survived heart surgery in the 1950s, but anyway, you know what I mean. Hopefully the principle stands, right? And I really, if you can tell it irritates me, you probably guessed well. And I think it's very unfair to everyone. ECT is an appropriate and important treatment for many people. We can talk more about it as questions arise, but I also get asked an awful lot these days about this treatment, TMS. The reason I put up this picture for TMS is, look on this guy, there's something weird about him. He's from Hopkins and he's meant to be a guru of TMS. It's just the way he's looking at the patient. I think, it's a bit weird. Maybe he just got caught at a funny moment. TMS, or transcranial magnetic stimulation, is a treatment that has evidence for major depression that hasn't got better with a couple of antidepressants. So we're in that treatment-resistant group. It's a bit of a shame that at the start everyone talked about it as the alternative to ECT. Because actually what the evidence is, that people with TMS who respond to TMS are generally mild to moderate depression. ECT is a treatment for moderate to severe depression generally. So they're different groups who respond. They're not the same, and it actually hasn't helped anything to compare them too much. I think people would love to have an alternative to ECT that doesn't involve an anaesthetic and probably isn't called ECT, because you know then the whole name has a thing, doesn't it? But TMS is a useful treatment, it's safe, and I have to say, most people like the idea. I have to say they do. Something about it seems kind of nice and easy in a way. It's becoming more widely available gradually, but is still not funded by Medicare. So hence, it tends to be accessible in private hospitals under your insurance, when really most of the people who need it and will benefit the most don't need to be in hospital. So it's a bit kind of a silly way of going about it currently. It should be amongst the list of things we consider, but I think it depends on the type of depression you've got. Move on quickly. Deep brain stimulation was the thing that the blogosphere was talking about a few years ago. Deep brain stimulation is actually a surgical technique, so we're not talking about any lightweight treatment now. We implant stimulators in the brain, in the areas thought to be associated with depression. Straight away, if you're thinking, gee, I think that's only something you'd try if things were really bad, you'd be right. It is available in Victoria. It's also used in the treatment of severe obsessive compulsive disorder, interestingly, and probably may work more consistently there, I think. It's done under a review board in Victoria because, you know, surgical operations for mental health problems, that's a kind of complicated area, isn't it? There's lots of issues in there. And we're talking about, in total now in Victoria, over about the last 10 years, about 20 people. So I don't want to talk about it anymore other than to say, this is really something that we'd be trying when things are really difficult and highly treatment resistant. I only mention it because people bring it up. And they also, oh sorry.
So what were the results with the 20 people?
Well, with all the limits of, you can't do a placebo-controlled trial of a surgical intervention, it was about a third, which is pretty crude science, isn't it? These were people, to get it, you have to really fail everything. About a third of people said, this has really very clearly made a big impact. I almost feel like I'm back to my old self. Wow, that's kind of wow, my God, this is fantastic. A third said, yeah, I think I got something out of it. Now, is that something, you've got to be careful, is that something about all the effort that goes in and all the work that goes into it? Maybe a little bit. And then a third said, no, don't feel any different. It's a very rough rule.
But did all of them get ECT? All those patients that got DBS?
Pretty much, yes. The answer is yes. So there's to get to DBS, generally there's a checklist of treatments you had to have had. That's for depression, not so much for the OCD ones where ECT bites unless you're depressed as well. ECT is not very helpful.
Just out of curiosity, how many ECT sessions do you require before these patients were decided that they must get DBS?
A proper course, at least, and usually quite a lot of other treatments as well. And in fact, most people, because people don't rush to this for goodness sake, most people will have had more than one course of ECT by the time they get to this point. Most people have really had an awful lot of treatment. That's probably the main comment I wanted to make, the sort of position where it sits, so we don't get confused. I did want to talk about this quickly, and I'm conscious of time. Something that goes, yeah.
What do you consider to be is a proper course of ECT? Like 5 sessions, 10?
Okay, it's a good question. The average course of ECT is 8 to 9 treatments. The response rate, certainly I did a study in our professorial psychiatry in Albert Road Clinic, shouldn't say that too loudly, should I? The Albert Road Clinic a couple of years ago, the response rate was 80%. The 8 to 9 treatments is an average. Do people get better in under 6 treatments? A pretty small percentage. If the average is 8 to 9, some people are going to have more than 8 to 9 by kind of definition. Typically that would be, sometimes we'll start with one type of ECT, and if it's not working we'll have to change during the course. Well, if it takes at least 6 or so to work out if one type is going to work, if you have to change, you're almost certainly going to have 12, aren't you? And sometimes we have this difficult situation where a person's got a bit better with ECT after everything else hasn't worked. How long do you keep going to see if they're going to have a full response? That can be a tricky decision for everyone, that sort of case. But 8 to 9 is the average, if that's helpful. Yeah. This is a study looking at ketamine, and I don't want to talk about the details of the study, but it was to remind me to talk about ketamine because everyone asked me about ketamine. So if you go to the blogosphere, ketamine. The main thing I want to say about ketamine is summarised. There's a College of Psychiatrists statement about it that would say, overall our level of evidence about ketamine is it is an experimental drug. So ketamine is not licensed for the treatment of depression. It is licensed as an anaesthetic.
For horses.
And for humans. When they put horse tranquilizer in the papers, it's a bit dramatic. It is used in humans. I think, to be fair to the horses, it's used in humans as well. Because of its action in the brain, there was development of an idea, how about we use it in lower than anaesthetic doses in people with depression that's treatment resistant? And lo and behold, in several studies, people found a pretty dramatic response in some people. And the graph was a bit like this. So this is hours, well it's minutes actually. This is 2 hours. You can see the ketamine people were already quite a lot better. No antidepressant we've got works that fast. So wow, that's kind of pretty exciting. By a week, by day 7, they were only slightly better than people who didn't get ketamine. So what does that mean? Well, an early result like that could still be useful while you're waiting for other treatments to kick in that take a little while. That could be useful, could be. The other obvious question is, well, what if you keep using it? Will it work? We're really just getting those studies now. This is given intravenously, which is obviously not very practical for repeated use. So people, there's one of the companies is working with an intranasal version related to ketamine. That'll be simpler to take and people can take it home. We have to proceed carefully. Ketamine in higher doses can be a drug of abuse. Ketamine was the #1 drug of abuse in Hong Kong about 2 years ago. The main reason why is because it was made cheaply in the mainland and could get across the water very easily. It was kind of interesting. It taught me that what becomes the #1 drug of abuse in the country is not just about people particularly enjoy that drug. It's about market forces, which is kind of sinister and dark to think about, isn't it? But it was interesting. So ketamine, it's not such a popular drug of abuse in Australia at this stage, but it's good reason for us to just go carefully. So we don't yet know where this is going to fall. So where does that mean it sits in my 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 list? A little bit below that. So when someone opened a ketamine clinic in St Kilda Road a few years ago, I don't know if any of you, it happened to be just near Albert Road, and so I couldn't help myself. I walked past one day and it had more of that black cellophane on the windows than you've ever seen. It's kind of really dodgy. And really they were, I think, trying to exploit well ahead of the evidence. So we still don't yet know where this is going to land. Results like this are pretty appealing, aren't they, if you're feeling terrible? You think, wow, you know, I want to be in that group who feels better in a few hours. Is it really going to fix the problem? Don't know yet. There are reasons to be cautious, and some of the evidence would say in the long run, not necessarily. So, when we've got troubles with treatments not always working, the next kid that comes around the block is always, it's sort of seductive, isn't it? You know, we all want the next best thing, and why wouldn't you? You see that happen in, you know, Alzheimer's research. How many times have you seen in the newspapers, drug that cures Alzheimer's will be on the shelves in 10 years. And then you don't hear of them again. And it's not that we've got nothing to treat depression, that's not true, but we don't have perfect things, so there's still that lure, isn't there, of, you know, the next magic thing. And that happens in biological therapies, it happens in psychological therapies too, and other sort of social ideas. If only you exercise, all your depression will be cured. Who said that? I've got some good news and some bad news. The studies show, yes, exercise can benefit particularly mild depression if you do vigorous exercise for at least 45 minutes every day. It's actually a little bit more taxing than you might think, particularly if you're severely depressed, right? You know, sure. So it's not the panacea. But is it useful for some people? Absolutely it is. And as a general thing for your physical health, it's a good thing. Yeah, of course it is. All right. So look, in conclusion, hopefully I've convinced you, treatment-resistant depression is a major public health challenge. 20% of 20% is a lot of people who are suffering for a long time, and that's a very bad thing. Our current treatments do work, not always, so it's important to stick with it, making sure we've got the diagnosis right, and I mean the diagnosis, the whole situation, not just literally the clinical diagnosis. That we use our managements well, including talking therapies. So I've talked a lot about the biological ones, but it's not because the other ones aren't important. And of course, we do need to keep looking for new ones as well. So, you know, research is definitely needed. All right, I kind of feel like I've ratted on for a fair while. I think we're scheduled till 8:30, so that leaves lots of time to chat. Any questions you'd like? Please.
Just, I think I know the answer to this and probably don't want to know the answer, but just to clarify one of your earlier slides, you're in the 4 years into that and still in the throes of an MDD and have had small ups and downs and ECT, you're no good. Your chances of pulling out of that are pretty slim, aren't they?
They're getting lower. They're getting lower. That study presents a particularly negative kind of feel, that one I'll show you. They are getting lower, but I think that's not surprising, is it? You know, if you said they were getting higher, you'd be thinking, what's this guy talking about?
Of course.
It is important that we don't get discouraged by that. So what we do know is, if people have tried a few treatments, it gets harder to get motivated about the next one sometimes, doesn't it? To not give up. So do many people who end up coming to see me, would they have been depressed for 4 years or more? Actually, the answer is yes, is the truth. And would they have tried quite a few things? Yes. And is the process, and I'm not saying it's me specifically, that'd be true for other psychiatrists as well, is the process then sifting out, first of all, let's go back over it again. Is there something we've missed in the big picture? Sometimes there is, sometimes there isn't. What have we done with treatments? What do I think about the treatments that have been used? What hasn't been tried? There's almost always something I can find that hasn't been tried, thank goodness. And people do get better. So yeah, the likelihood you're going to get better in the next week is getting less. but the likelihood you'll get better eventually is definitely still there. And that's really important. Really important. Please.
So how much weight would you put on psychotherapies then? Because it's something you just haven't cleared.
No, as I said, and I'm happy to repeat it because it's really important, it's not in any way to diminish their role. It's kind of, I think that the ask of me was to talk about this stuff.
Okay.
If you look at our college mood disorder guidelines, they say in mild to moderate major depression, first line treatment is structured psychotherapies like cognitive behavioural therapy or interpersonal therapy. Moderate, you could argue that, or antidepressants, and people have their preferences.
But why not in conjunction as well?
Absolutely, and I often think it's a slightly crazy thing, that it depends whose door you knock on, which treatment you're likely to get recommended, and I think that's wrong. I think everyone has a right to information about all their options. So when a person comes to me, we would go through, if I didn't recommend this, why not? And what about from this sphere and this sphere and this sphere? And equally, within the psychotherapies, it's important to be clear about which ones have the strongest evidence in the treatment of depression. It's not necessarily the one that person was trained in last weekend at an expensive workshop. There is a body of evidence, just the same as with medication.
It needs to suit the person.
It does, but that also needs to involve a discussion about what works. Because particularly in talking therapy, and medication's sort of the end of the day, isn't it? But in talking therapy, one of the commonest quotes I'll hear, I used to see Fred or Betty, or it doesn't matter, they were really nice. I loved talking to them, I loved seeing them. How long have you been seeing them? Sufficient length of time. Did it help? The answer is not really. Well, I don't think that's, I'm not saying Fred or Betty's being mean, they're obviously trying to help. But actually, I don't think that's really good practice. At some point, you should be reviewing and saying, actually, this treatment I'm offering might not be the best thing for you. And I think in therapy, it's easier to roll on sometimes. Whereas with the medication, people are probably a little more likely to say, no, chuck it out, I think.
Can often be just about making people feel better, but it's not about change.
Yeah, and there's nothing wrong sometimes with supportive therapy as long as you're clear that's what it is. That's okay. So sometimes where it's not easy to get better, support can be really, really important. I don't want to diminish that, but be clear about what it is, and that's about good structured review as part of therapy, isn't it? Okay, we're going to do this, and then at this point we're going to stop and say, what do we think? I think that's really important. That'd be true in any treatment.
What about the changes in neural pathways having a relationship in therapy?
Well, there's a series of studies now that look at both structure of the brain through an MRI and function of the brain through scanning like PET scanning or even functional MRI. They show in a range of disorders, perhaps best shown in some of the anxiety disorders, that if treatment works, it produces or reverses certain changes, and it doesn't matter what treatment it is. The first INVEST study, I still think, was one looking at obsessive compulsive disorder. So obsessive compulsive disorder can be treated with high dose medicines that increase serotonin or exposure-based cognitive behavioural therapy. Great study, looked at a whole lot of people with OCD who were treated with whichever, and it showed that in those where treatment worked, didn't matter what the treatment, activity in the brain changed this way. If the treatment didn't work, didn't matter which treatment, it didn't change that way. I thought that was brilliant. In depression, we actually, surprisingly, probably don't have quite as many studies, but there are a couple that separately look at antidepressants, where they work and what activity changes they produce, and CBT. And they look a bit the same. We often, it's interesting when we talk about when I talk about brain changes in depression, people often assume that the only thing I therefore talk about is biological treatments. Your brain is connected to your body and the rest of the world. Depression is an illness. We've tried to blame it on a few other parts of the body. We had a go at the liver, we had a go at the gallbladder, had a go at the heart. I think we had a go at the female reproductive organs at one point. It's a brain disease, and if you treat it effectively, no matter how, it'll make changes in the brain. And I think that's really important. It's a great question. Because once you start thinking that way, it really opens it up a lot more. Please.
My question was related. I work in acquired brain injuries, so I'm interested in that, but I don't know a lot about depression, but within depression, is there a common brain change, and what's the nature of that? Or are different depressions show a different brain change?
We know some. Part of the limit on how much we know is about two things. A bit like in ABI, we're limited by the fact that there's a skull in the way. So if we're worried about your liver, we can stick a needle into it and take a little bit out of it. There's not many ethics committees in the world who are going to be very keen for me to stick a needle through your skull into your brain and take a little bit out of that. They don't tend to favour that, do they? It's ridiculous. So we've got a black box that we can only image indirectly. MRI, even the best MRI in the world now, has a limit to resolution. It can't go down to a cellular level, which is probably where most of the changes are. So I can't do an MR, stick it up on the wall and say, that's the MRI of someone with depression. Can't do it. Any results we're talking about are, on average, in 100 people with depression compared to 100 people without, but an individual scan, no. In those big groups, you see that if there are changes in the brain, they're generally in the front half of the brain, frontal and temporal lobe, and we know, when working with people with ABI, how important they are in the regulation of emotion. Generally, your frontal and some of the structures in the frontal and temporal lobe are kind of in a dance. It's kind of a nice metaphor, isn't it? Bits of your brain dancing with it. That your temporal lobe encodes emotion, particularly parts like the amygdala. So when you experience emotion, it fires up. If it's emotion linked to a memory, so for example, I'm driving down the freeway at a safe speed, just to be crystal clear, driving down the freeway at a safe speed, and I have a nice memory from, like when Richmond won the premiership, my amygdala will fire up and I'll have a warm glow. A particular part of my frontal lobe, the anterior cingulate, will say, yeah, that's nice, Mel, but you are driving on the freeway, could you please concentrate, in effect, and we'll regulate that emotion. That balance is disturbed in depression. I've simplified it a lot. That balance is actually also disturbed in other conditions, PTSD, for example, which kind of, you can see how it would be in PTSD. So, it's the frontal and temporal lobes. There's also an interesting question, well, if you have depression frequently enough, is that reflected in actual change in the structure of the brain? There is a little bit of evidence, again not at an individual level, but in big groups, yes you do. That kind of fits with the more times you have depression, it can become a bit easier to have it again. We don't want you to get there. We want to stop it early on. You know, they're not dramatic changes. So will we reach the day where I can put a scan of some kind up on the wall and say that's a scan of a person with depression? I think we're a long, long way from that. It's probably the short answer.
Now, you mentioned with ECT how difficult it is to actually have a control group or, work out what percentage of the result is from a placebo effect. I'm guessing the same would be for TMS.
Yes.
Any estimates of how much of that is a placebo effect?
Well, ECT, there are, believe it or not, placebo-controlled studies, which consisted of a person went and had the anaesthetic but no ECT. They're not done recently. The last one was in the 1970s, and you wouldn't do them now. That just would not be justifiable. But they were really important in demonstrating how it really did work. It's a pretty important question. TMS, the equivalent, has anyone had TMS? Yeah, the clicking noise.
Yeah.
It's a bit of a dead giveaway, isn't it? The placebo control is to turn the magnet through 90 degrees. So it's not influencing your brain, but you still get the clicking noise.
Yeah.
However, some people also report a sort of tingling feeling in the scalp, and you won't get that if it's turned through 90 degrees. So I have my doubts. I have my slight doubts. TMS is an interesting treatment that there are people who are passionate believers in TMS amongst psychiatrists. There are people who are, just like there are Eurosceptics, there are TMS skeptics, and I'm probably somewhere in the middle for whatever that's whatever my things with. Somewhere in the middle of saying, this is what I think the evidence says. I think, like any treatment, if anyone tells you this is the cure for everything, be sceptical. And that will be true for anything. Please.
Yeah, well, I've had ECT, I'm not ashamed of a couple of courses, but I'm nearly 70 now, and apparently I've got short-term memory loss, but it's affecting my relationship with my husband and children.
Oh.
Can't remember things.
Okay.
So that's pretty unfair, don't you reckon?
Well, what do we know about ECT and memory loss? Because memory loss is certainly a pretty important thing in life, absolutely. The first thing to say in thinking about that is that the way we give ECT has changed quite dramatically from, I'm trying to think of the best way of saying it, a few years ago. It's changed quite dramatically. Without going into the physics too much, because I'm not sure I'm the expert in the physics to go into it, we deliver the pulse in a very different way. We've defined much more clearly what it is we need to do to make it work. And so the newer methods have reduced the confusion that people feel a great deal. So still, confusion in the hour or so after treatment is pretty common, and you wouldn't be surprised by it in a way, would you? You can't expect that. People often lay down new memories during, if you're going to have 8 to 9 treatments 3 times a week, that's probably 3 weeks or so. People often lay down new memories during those 3 weeks, not as well as normally. Of course, many of them already weren't laying down new memories probably because of severe depression. And actually, if you do a big study of people who have ECT, this is an interesting result. More people have better memory at the end of the course because it's treated their depression. The more important question, and some people would say, well, that's not good, but if I only forget bits when I was having the treatment, that's, the bigger question people worry about a lot is it going to have long-term effects, which is kind of your question. It's only recently we've got good quality studies looking at that. They do say that effect on new memories, that can take a few weeks to go away. Most people, once they've stopped ECT, it starts to come back fairly quickly if everything else is okay. If they're still depressed, that may still affect their memory. If they're on medicines that are sedating, that can affect their memory. So there can be lots of other things that affect memory. You still hear those reports, and there was a really good insight program on SBS about ECT 2 or 3 years ago. I thought that was really great because a lot of the telly about ECT is kind of very dramatic, and it was good. And they had one lady there who had ECT quite a few years ago, and she said, it did affect my memory, including very personal, what we call autobiographical memories, like really important events in my life were affected. Well, that would not be good. That wouldn't want us to say, of course it's not good. They're a key part of who we are, aren't they? Funnily enough, your autobiographical memories, they're the hardest ones to test because they're so individual. But actually the modern studies say if that happens with new ECT, it's very rare. We usually monitor for it during the course. So I feel comfortable recommending ECT. I don't have any problem saying that. It's a powerful treatment, it needs to be monitored carefully, and it needs to be for the appropriate person. That's very important. But it's really important, it's a treatment that's changed quite a lot, and I don't think we talk about that anywhere near enough. I hope that was a bit, and good luck with it. Please.
What are your general thoughts on diet?
And depression, yeah. Well, there's been this really interesting evidence that Felice Jacker and others have put out recently about are certain diets associated with both a lower risk of depression and maybe even improving depression. I think the jury's not completely in yet about whether you can treat depression with diet alone. But I think in our guidelines talking about that lifestyle part, do we now say talking about good diet is absolutely important in everyone with depression? Yes, partly because we know physical health is often at risk for depression, if nothing else. If there is evidence for any kind of diet being helpful, it is currently with the Mediterranean diet. And in answer to the question, look it up, all the bits in the Mediterranean diet, because I'm not an expert on what's in the Mediterranean diet. But the Mediterranean diet, if you Google that, you'll get a good rundown. Lots of nuts and other things in there. Interesting.
Heaps of omega-3 fatty acids.
Well, yeah, but other things too. Omega-3, people got very excited about omega-3, didn't they, as a treatment for depression. And there is some evidence that combined omega-3s, there's a couple of different types.
I mean from fish, natural sources, okay?
Yeah, well, the evidence is where there's some evidence that can help treatment, unless you eat an awful lot of fish, you probably won't quite get enough. You need to go out and buy those smelly capsules. You wouldn't want to eat smelly fish, would you? Smelly capsules. And they're reasonably widely available. But if you do buy them, make sure there's two types, main types of
omega-3s.
Omega-3s, thank you.
Yeah.
EPA and DHA. And it's got to have both to be effective.
Yeah. But I mean, the other thing about diet is there's growing evidence, there's quite an explosion in this evidence now, that gut health is crucial because 70% of the serotonin is produced in the gut, not the brain.
Sounds good. And certainly a good area of exploration. So, has that yet led to a treatment? And I think the answer, unfortunately, as yet, is no. Interesting, yes. May lead to something, yes. Sometimes these patterns of thinking are pronounced as if, aha. But the real question I always ask is, great, and maybe there is something in that, I'm not disputing it. But right as of now, what's the evidence that that leads to this treatment that will make the difference? People often leverage off that idea to say, therefore, if you have this diet, it will definitely be better. Well, maybe, but until I've got the evidence, I'm going to be a bit sceptical.
I'm not saying that.
No, sure.
I'm just saying we need to think holistically rather than just the brain.
The brain is definitely connected to your body.
Exactly.
Yep,
exactly.
Absolutely.
Yeah.
At least hopefully. Definitely. I couldn't agree more. Please.
Hello. Sarah, I've read one of your papers about the use of stimulants with Professor Jim Mully.
Yeah.
And I know that in the United States they use a lot of stimulants as a combination. What are your thoughts?
Yeah, oh, thank you for reading it. I apologise for whatever I said. No, it's not true. Yeah, we wrote that paper. Most of those people were in the group that wrote the guidelines for mood disorders. Stimulants, the idea of using stimulants, so by this we mean things like methylphenidate or dexamphetamine that are often used in the treatment of ADHD and have good evidence there. The idea of using things like that to treat depression, even amphetamine originally, has been around for a long time. So when amphetamines used to be freely available, someone in the room might remember Ford pills. Ford pills could be used for dieting, but lots of people used to use them to try and treat depression. They're amphetamines in a jar. It's kind of extraordinary thing there. So the idea's been around for a long time. And it sounds like it should be right, doesn't it? You know, a stimulant, you're depressed, you slow it up. Sounds like a good idea. What we raised in that article is what's the evidence that it works? Because you're right, it's widely used in some parts of the world as an augmenting thing to boost antidepressants. Actually, when you look at the evidence, it ain't that clear. There's lots of case report things where people say, I treated 3 people and they got better. Well, that's interesting, but that's not really great evidence, is it? Because that could mean anything. The best studies we've got of the use of stimulants are with the compound that's a long-acting stimulant, not available in Australia. There's some big studies done in North America, and they want to see if it could be used in major depression. The manufacturers were kind of keen, I think, and they got to the last phase 3 of trials, where you've got hundreds of patients in either arm using it to add to antidepressants, and it failed all the trials. So I think what we're saying in that paper is actually deep down, the evidence for using them isn't that good. Like a lot of these things, does that mean they never help anybody? No. But it does mean, in that list 1, 2, 3, 4 for me, again, they're right. They're not quite as far down as DBS, but they're well down.
Sorry, one more question.
No, please. The first one was good.
As a medical student, I'm really interested to know what are your 1, 2, 3, 4s?
No, good question. And the first part of the answer, and I know it might sound a bit obvious, but it is important, is it depends. And it depends an awful lot on the person and their presentation and their preferences. Best treatment is the one the person agrees to take. The most useless treatment is the one that they say they'll take, but they're not really going to. That's useless. Look, I will tend to see severe depression. And that's as should be as a specialist, I think. You should be there for the things that are a bit tougher. But if I looked at the whole field of depression, if I could be both a GP and a psychiatrist at the same time, it's a kind of weird thought, isn't it? I think the guidelines say for mild to moderate major depression, it's perfectly appropriate to have structured psychotherapy like CBT or IPT as first. But if a patient says, I don't want that, antidepressants also have evidence in that setting. Probably these days more people like to give psychotherapy a try, but for some people psychotherapy just isn't their way of the world. It isn't. Second treatment might be swapping those two around. If they've already tried one antidepressant, usually I'd go to a second antidepressant from a different group. Different mode of action. After that, number 3, it kind of depends. Review the diagnosis, think really carefully, have I missed something big here? Then depends a bit on severity. The commonest one probably be adding one of those augmenting medicines, if in the medicine area. Yeah, probably. ECT might be in the mix, depending upon severity. Yeah. If it's milder, TMS might be more in the mix. And plus or minus therapy and social interventions all along. The things that influence how much they're in are about severity of depression. Psychotherapy is less likely to be effective in the most severe depression, on average. There's no point giving someone a therapy that's not going to work. But that would be a sort of common flow, if that helps. But it does, of course, depend on the situation. And if a person's had depression before, a big factor is going to be, well, what worked last time? That would be a good question to ask, wouldn't it? Right.
So you have an expectation when you prescribe the medication that it has a chance of being fully effective?
Yeah.
It is going to be what will fix it?
Well, yes. The way you said that statement, it almost sounded like that's the only outcome. Right?
It potentially will fix it.
Yes.
All by itself.
Yes, it can for some people. As can psychotherapy for some people. So if you look at medication response, 40% of people on an antidepressant have a full response, get into remission. What about the rest, the other 60%? It's probably half of them will get something out of it, and another half, so about a good 30% get nothing. Generally these days we really are looking for that full response, so rather than settling on, you're a fair bit better, that'll do, I'd be more likely to say we better do something else, better keep moving. Really want to get you fully well because that's the best way to keep you well for the future. Alright, someone's phone was telling me it's 8:30. Yeah. Alright, thank you very much for your attention.
Thank you. Thanks very much, Mel, for a fantastic seminar. You're a pleasure to listen to. Your enthusiasm for your subject matter really shines through, and it makes it very easy to listen to, and I hope I can get you back next year.
Yeah. Cheers.
Thanks, Mel.
Thank you. Thank you.
Thank you.
Not too much.